friends. Nice to see you in a different format. I'm sure we must have met in many conferences before, but wonderful to connect to you through this virtual webinar of World Ophthalmology Congress. Today I'm going to discuss something very interesting, a multimodal imaging device which can improve the safe clinical workflow. The device I'm going to speak today is ANTERION. I know financial interest. I've been a researcher working on different Heidelberg platforms. It's important that I use the word improve clinical workflow is because of the state of affairs we are in. So that's the whole crux of the, that's the whole story behind this whole topic. So these are my financial interests. As we look at the evolution over the years, if you look at different topographers, started with Ridley's contact biometry, topographies, optical biometry, abrometries. These are all the evolution which we have seen. But what is important here is now every single diagnostics makes person move from one machine to the other. And he keeps moving, and it's a time factor. And in today's scenario we are in, every time you move, you're more in risk for the patient and also for the whole hospital and the technicians. So this is what is the major fear today, the COVID-19. That's the reason we are trying to connect to this. Last few months, we've been working on some myths of aerosols and droplets. We call the myths and science of aerosols and droplets, which has got a small impact to the presentation today. So we call it as the Appear series, and this is what we are worried about: the contamination of droplets, which can have an impact, especially when people move. So this was a study which we designed where we used lubricant drops, and then we did some non-contact tonometry, and we found that every time the patient moved, there will be a lot of splash of these aerosols and drops. These were captured by very high speed imaging. So basically what we are trying to say is that every time you are making somebody move from one place to the other, you are impacting, you are creating a lot of unwanted droplets and aerosols, which we don't want at this point of time, because sterilizing, cleaning and all is going to be a major factor. So can we have all these modalities of what we use in our anterior segment outpatient built into one? So ANTERION, the multimodal device, is an all-in-one program. Now, how does it work? The principle is based on swept source OCT. It has got a wavelength of 1300 nanometers, digital resolution of less than 10 microns. I mean, it's the best in the league at this given point of time, and it can go at scan depth of 14 millimeters. What are the features it has? It's a 4-in-1 platform. You have an imaging app here. You have a metrics app, so you have a cataract app and a corneal app. So my whole presentation is trying to go into every single metrics of it. So if I go back to my the whole imaging, we'll be starting with the metrics app. So you're looking at the whole anatomical structure from the epithelium, the stroma, the endothelium. You have a trabecular meshwork, the sclera, the serial body, and the beautiful lenses. And look at the beauty of this. This is what got very impressed to me. You know, the anterior lens capsule, the posterior lens capsule, the scleral spur, amazing clarity. And this is what really impresses somebody who wants to look at an anatomical structure. And this is how the whole structure is. So looking at how we are going to use this, so we start with the cataract planning here. And when we look at the cataract planning, this OCT section visualizes the entire anterior chamber of and representation of the retinal profile even through a dense cataract. This is very important because the first question people ask me is, can it pass through a dense cataract? Cataract as dense like this. And we move to this is the spikes, which is necessary to know that you're getting through a good denser cataract. It gives you an automated axial length. You can see that length, automated lengths are given here. You can see the images of the eye and all the other parameters, which we'll discuss shortly. And then if we are looking at, this is the same axial length measurement which I showed in the previous scans. And you can change the eye status. For example, if you are trying to look at a phakic eye, the phakic IOL, aphakic mode, pseudophakic mode, piggyback IOL. So you can use different modalities. So you can choose the eye status, and it will help us in trying to give a proper biometry based on the status of the eye, which is again a new features. And of course, a huge bunch of IOLs out there. Once you have a formula, which we'll discuss now, and you can just log on to any of those formulas, and you can choose the IOLs, and you can even change your eye constant. And these things are all quite common, like the enter target refraction and how it gets you selected from your IOL database. So basically, it can penetrate to a dense cataract. You can choose the mode of the state of eye. You can have a big IOL database from which you can get your IOL power, IOL formula, and basically it's all in one program built in out there. So which will help you to get exactly what a cataract surgeon wants without trying to take up too much of time. And you can build your own IOL constants also. This is the screen which comes in the machine where you can build your IOL constant. In fact, if you want it for a particular lenses. And beauty is that it can pass through mature cataract, many places, where we work in, and you can see the type of the dense, how there is a liquefaction here, how the dense here, the posterior capsule, beautiful representation of the lens, especially if you're trying to link it up with your the femto-based cataract procedures. And this again we have already mentioned, even as thick as dense as this, it can pass through, and that's what people want. Can it pass through a denser cataract? That's why I'm repeating it 2 or 3 times to know that it does. And we have done some studies also on that. So there are times when you can enter manually also the axial length, so that you don't, in case you're not getting it, you can take it from any other immersion-based biometry and enter it. The posterior polar cataract, again, this is where the challenge is, and sometimes it's very useful for a cataract surgeon to know, is it truly a posterior polar, or it's just if there's a breach, or it's just an opacification. For example, in this case, you can see that it's an opacification, and you don't see the breach here. So when you're planning for your cataract surgery, it really helps to know the status of your posterior capsule. And in this case, there is a pre-existing breach, and you can see here there's a breach out here. So you can already know that this patient will have a problem or a complication during your surgery. So it's very important, because if you're planning, for example, in this patient, there is a giveaway of a posterior capsule. You can see there is the breach, and this extended, and this is the same patient which clearly demonstrated that there is a breach in your posterior capsule. So it's very useful, because at one shot you know these, you know your formulas, you know your lenses, you know which IOL to choose, you know your status of the lenses. Is it hypermature, or is there a liquefaction clefts there, or you can even know if there is a breach in your posterior capsule. So basically, it's just not giving you a formula or an axial length, or it tells you much more than anybody else can do. Coming to the cornea application, see, I'm speaking from a cornea application from a purely a cataract surgeon, because many times cataract surgery, we miss out the most important thing is you miss out the topographies. And but it can be used here. The cornea apps can be used for a refractive surgeon also, because it has a single view, it has like your pentagams, it has your 4-view comparison maps, follow-ups maps, and also the multi-view maps, which tells you the change, which tells you different types of maps. For example, I'm looking at an axial, tangential, elevation maps, exactly like how you have in your pentagram or a cirrus, the best fit sphere, the best fit toric ellipsoids, the posterior surface of the cornea, exactly the same thing which is there. So it is a beautiful corneal tool. It uses a completely different technology, unlike the Scheinflug or the Placido. So it is very, very repeatable in its what it's trying to give us. For example, if you're looking at this kind of a map, this is a huge box out here: anterior curvature, posterior axial curvature, the total corneal power, the total pachymetry, the pupil, the angle kappa. So all these things are all very important for a cataract surgeon. For example, SIMCAs are very important because that's what we use. Posterior corneal astigmatism is important, especially if we're looking at an irregular cornea. Total corneal power, very useful for many formulas which we are trying to use. And especially if you're trying to look at a toric planning, and this helps to each segment of your total corneal power can be given. So these are the maps for the toric planning, and tells you the lens and axis, the orientation, and it has its own toric planner. This total corneal power can also be added to your holiday formula, which helps to plan your incision. And when you plan your incision, it tells you if you put your surgical induced astigmatism, it tells you the IOL location, the incision planning for the residual astigmatism. So basically, it's like you get your topography, get your biometry, get your topography, feed in your data, put all the data you want, and what you get is that it even tells you, okay, this is an axis based on your SIA. This is what your residual astigmatism is, and what axis you need to put. So basically, for a cataract surgeon, this is amazing because you get everything at one go. And for a premium surgery like a multifocal surgery, this is important. One is your pupil and the center XY angle kappa. And we know that angle kappa more than 0.5 is something which is not accepted. This gives you at one go, apart from all the other things which I mentioned. And of course, if you're looking at a posterior corneal astigmatism, post-refractive surgery eyes, or you are looking at an IOL power for keratoconic eyes or suspect keratoconic eyes, and posterior corneal astigmatism plays a very important role, and that is something which is already here, which is already given here, which can be incorporated into any of your formula. This is something which many other machines don't give you. This is the aberrations many other biometers don't give you. Aberrations profile, like one look at the aberration of your cornea is very important, because we are always interested in the lower order IRMS and lower order aberration and higher order aberrations. If you have a higher order aberration which is higher, you know that you cannot use your multifocal lenses. So summarize this part. You have a biometry, topography, toric planning, the fantastic corneal curvature mapping, and then comes your beautiful aberration profiles. Aberration profiles are very, very important because it tells you, is my patient going to be happy with your multifocals? Am I doing good on the multifocal point of view? Even there are best biometers in the world, but if you don't know this, your perfect IOL formulas don't really help you. The perfect IOL surgeries don't help you. You have to understand the corneal aberration, and that is what it gives you here. And this is what I said, the lower order and higher order aberrations, which is very, very important. In this case, it's little on the higher side. Post-refractive surgery planning is very important because you have a flat cornea. There's a multiple other aspects to it. Your anterior and posterior curvature are different. Here, what is interesting here is you have an inbuilt Barrett Haggis formula is inbuilt there, and it's easy for you to take the values from your topographies, and then values from your topographies and biometries, and probably incorporate here. So we don't need to go to the ASCRS calculator, online calculator, because it's already inbuilt here. And you can choose your IL based on spherical aberrations. You can, because this is again, a lot of people use extended depth of lenses now. EDF lenses have come in, and most of the time when you have an extended depth of focus lenses, it's important to understand there is also a component of the corneal plane. So when you have a corneal plane which has a different aberration, the depth of focus lenses would behave differently. So knowing the spherical aberration is very important also in planning your multifocals, and also planning your extended depth of focus. So it's just not your simple uh, biometries or topographies. You can play around the optical tools. So basically it's more, when it helps you to look at the multiple dimension of what it multiple dimension and multimodal of what it does, and try to build your premium practice. For example, this is something simple about different types of IOLs which can be used for different types of spherical aberration, and this can be just got from one of the screen buttons when you're trying to look at the spherical aberration. And this is a screen which tells you different formulas, different Holiday, SRKT, and now we have Barrett. Also formulas for IOL selection. So you have for the monovision or multifocals, and now this is the Barrett formula which has been incorporated recently. So the question which comes always is when you have a new technology, the first question is, how does it compare with the best? And the best two biometers we have today are the Lenstar and the IOL Masters. So when you look at the curvature mapping, the Lenstar, IOL Master, this is something, this is the paper which is in the final review. And we look at all of them, and we found that they were very comparable in the keratometry. And this is the most important thing. The two important thing in biometers is keratometry and the axial length. And you can see that the Lenstar, IOL Master, and Anterion were very, very close to each other. That means that if you are comparing with the best, it is equal, and it does exactly the same thing. Probably what it scores over the rest is it gives you much, much more than what an IOL Master or a Lenstar would do at this given point of time in present circumstances. And the white to white, again, it matches very close to the Lenstar. And the lens thickness, absolutely all of them are bang on. So that means that virtually in all the parameters we studied, they're very close, and interclass coefficient correlation repeatability was very, very close to all of them. This is very important because we need to have a very good repeatability, and that is what it gives you. So the axial length, the keratometry, the repeatability, everything is perfectly similar to the best in the market today. So that is what this paper just says. So coming to the topography point of view, it is always important because we need to know how good is the topography compared to the other tools which we have. Traditionally, what we do is, like I said in the beginning, we have a biometry, and after biometry, you take the patient to a pentacam or a cirrus, then to the something else. So here, everything gets all with one go, and this is how the topography looks. And you also have the anterior segment picture. And if you look at the single view of this, this is a single view of topography on the eye, and this is the anterior segment OCT picture. And these are the pachymetry map, the total cornea. It's something very similar to what we have in most of the maps, and this I've already shown you about the wavefront aberrometry maps, and the utilization we all know. And beautiful keratoconus picture you can see, and then aberration maps out here. This is the wavefront aberrations in the keratoconic eyes. And these are the comparison maps if you're using it for keratoconus follow-ups or post-refractive surgery follow-ups. Now the question comes: I match the biometry with the best of biometers. The second question is always when a new tool comes is, okay, now tell me how does this topography match with the best. The Pentacam and Cirrus are the two top topographers in the world today. And if you have a topographer, people would always ask, and I would always ask, how can it match with the best? And we did compare with the Pentacam in many patients, both the normal as well as irregular corneas. We are writing this as a manuscript and we should be ready shortly. And you can see that absolutely the posterior elevation here, you can see that elevation, you can see the inferior steepening which matches, and the Pachy matches exactly the same. So basically you are, and this is a normal corneas, and this looks exactly the same. Both the Anterion and the Pentacam gives the same picture. So that means basically you're exactly matching to what we see on a Pentacam. So which means that your topographer is in sync with the best in the league. So that is something which is very important, and it gives us a lot of confidence to the doctor that, well, I'm not using something which I'm not sure about. So what is our experience on this? And you can see that the curvature map matches, the pachymetry, exactly pachymetry matches, and curvature is just by around 0.25. That's okay. That comes, that's considered okay. And ACD is more or less the same. And higher order aberration also closely matches, even though there are two differing technologies. One uses shine plug, one uses the spectroscopy, but still they match very, very closely, which is very good because it builds a tremendous amount of confidence. What happens, how do we use it other than the cataract and the topography part? We can use it in multiple areas. We can use it in your ICL planning. Amazing tool. My colleague is going to speak about it. You know, STS, the sulcus to sulcus, white to white, angle to angle measurement, scleral to scleral per distance is what it gives, and anterior chamber. All these parameters it beautifully demonstrates. Very, very useful for the glaucoma surgeon in today's context. Again, today's context is more about trying to use it as minimal invasive as possible because of the scare we are in, and gonioscopy and anything which induces tears has always a risk of contamination till we really know what is happening. And at this point of time, this anterior chamber angle parameters are really helpful, and scleral to sclerals per distance also beautifully demonstration, and angle to angle measurements all can be given, and the lens thickness and the lens vault. These are all very useful, especially in you're dealing with an angle a closure glaucoma or a closed angle glaucoma, and this is something which is very important. And also for the glaucoma specialist, the pachymetry comes directly over there, and this is very useful in our practice. Like I said in the beginning, in today's context, having all of them. And lens vault is something very new. It tells you the lens vault, and this is how you measure it from the angle to angle, and then how far it's deviated from there is what gives you in a lens vault, and it's given in this measurement out here. And basically how we do is distance between anterior lens capsule. This is your green is your anterior lens capsule, and lens drawn between the root of the iris, and the lens drawn between the root of the iris, and that distance here would be your the angle to the lens vault, which is very useful. This is post ICL, the ICL vaulting, which we have been using, and it's just a case about the low lens vault and how it has an impact on the lens can be determined, and whether you need to exchange the lens or you need to position is better is something which can be used. Which can be done based on these scans. These are high lens vault. Again, you can see the change in the angle out here, and you can see the amount of distance and from the capsule, and how the lens changes, and beautifully demonstrated in at one go. So not only for the cataract, it has a huge role, and in phakic lens surgery. In today's context, phakic lenses are used very commonly, patients who are not suitable, and many times it's the first line of surgical procedures for a refractive surgeon. Again, the comparison is a thief of joy, but still, we had to compare. We compared this with one of the best modalities of anterior segment imaging from CASIA, and you can see that when you're using with this, the vault is more or less the same between both the scans. And finally, coming to the role of this as an anterior segment tool, and you can see that DSEC images. We can see that this can be used by the cornea surgeon also, and the cornea surgeon also can look at multiple things: the host junction, the anterior chamber depth, the lens thickness. For the intact surgeon, the role of how the intact is placed out here, and the depth of the intacs can be looked at. And this is a lens glistening, IOL glistening in one of our cases, and we can see that how it looks at. What are we looking at it in the future? It's a complete multimodal device. From looking at it, from looking into the future, what we request, what we are waiting for is probably helping in trying to understand the dysfunctional lens grading. Grating, this can be done. I don't think it's too difficult, but it's something which can really help in understanding very early cataract changes. Desperately need an epithelial thickness. I'm sure they're working on it. It's something which can probably come in the future. So from a multimodal device for the patient care, I consider this as 2.5 to 3 minutes of imaging, where the patient comes, sits on the machine here, puts his chin rest. He gets this imaging done, the entire imaging done. If he's a cataract patient, he gets a complete cataract imaging done, which includes biometry, the lens tail, the lens dimension of the lenses, the lens thickness, the axial length. It is all that what the biometry would give. The complete biometry would be done, and after the complete biometry, you have a range of options for you, depending on what kind of eye you are looking at, and how do you look at what kind of eye. If the patient is a keratoconic eyes, I would consider out of 500 patients we see, around 6 or 7 of the patients have keratoconic on topography, which we have never seen. The patient has never seen, or so ophthalmologists have never picked up. So you can look at, oh, that's a keratoconic eye, so I can help to look at, okay, I choose the kind of formula I want, or it could be a post-refractive one. So basically, and if it's a patient with a shallow angle or very close angles, the type of cataract, the posterior polar cataracts, you name it, you have it. And what happens is it's become so easy for a surgeon. After the 2.5 to 3 minutes of test, you just sit with your screen and plan out what you want, pick up the type of lenses you want. If you want to adjust your own IOL constant, you can do that. If you don't want to do it, you can have an array of lenses. Choose the type of the type of technology you want. For example, if you have a posterior polar and you know that there will be an issue, be careful, take extra consent. You are trying to be safe for the patient, because if there is already a breach, there is a chance that the lens can go can have a nucleus drop into the posterior vitreous. So, and from a cornea point of view, it's just like you're having a pentagram. So basically, at this point of time, you have your best of topographers, best of biometries, best of imaging technologies, great tool and software for a glaucoma specialist, which is from an imaging point of view, all loaded into one machine, and patient has to just sit for 2.5 to 3 minutes, or even less than that, depends on how well your patient is cooperating, and you have everything ready for you, and the patient just walks out of that place. In this today's scenario, with major thrust of uh, fear of aerosols, and I did show that when especially you use multiple tools, your eyes are watering, and then you have a problem. So major thrust is to see that if you move from one machine to the other with a watery eye, then you are spreading the aerosols all over. You have to have everything at one go, and this is the go at this point of time. And I feel in today's era, this is what would be the best way to move forward. And thank the organizers of WOC, and also the team from Heidelberg, Stephen and his colleagues, for helping me to present this and sharing this with you. See you in better times, and I'm sure everything will be all right. Just a matter of time. This too will shall pass. Thank you.